Hi, everyone. Thank you for being here tonight. I know it's getting a little late too, and just taking what Jennifer presented and applying it to more specific things that could apply to your patient population in terms of the anorectal conditions. And I'm really grateful that Jennifer just set that up because I think it's so important as we are learning more and more about our second brain being the GI system and how people have this interconnectivity between GI issues and any kind of, brain dysfunction that may be happening. Again, my name is Pani Nazari. I'm a physical therapist. I've been doing pelvic floor stuff for the past, since early 2000. I did orthopedic, I still do. And I started a program of pelvic floor health at Virginia Hospital Center in Arlington, Virginia. I was there for 18 years now. I have my own clinic in McLean area and just doing what I do with the pelvic floor stuff. So moving on to my presentation, I gonna move on to the next slide.
Yeah, sorry.
Jennifer is going to help me. No. I just, most of you may be familiar with the pelvic floor rehabilitation and what pelvic floor physical therapy is part of it. I've been very grateful to have this ability to apply what I've learned based on personal experiences and other things to teach and educate not only providers, but patients as well in terms of what is pelvic floor physical therapy, which throws a lot of people off still to this day because we do internal work, we are addressing the musculoskeletal system that is in the pelvic girdle area. So still people come in to see me, they're like, you're gonna do what? But basically just addressing and it's a very non-invasive, non-surgical approach for any kind of pelvic floor dysfunction that may be, creating the GI issues or the GI issues that may cause pelvic pain or even musculoskeletal issues that can present in terms of visceral discomfort that we can address. One thing I would really highly recommend is that if you refer to pelvic floor PT, making sure that they really have good training because unfortunately, it's a big buzzword right now, and a lot of people claim to be pelvic floor therapists, but doing really just using equipment and not doing a thorough assessment. So in terms of the assessment of the pelvic floor, when we see a patient with different type of diagnosis, in a general senses, we do look at the whole person. And I think looking at the person holistically, just piggybacking on what Jennifer was saying from the psychosocial approach, biopsychosocial approach, I should say, is looking at their posture, looking at the stressors that they have physically and emotionally, any kind of musculoskeletal assessment that can include how is their thoracic spine moving, if their diaphragm is not moving because they have some, or expanding with every breath because they have had some injuries, or everybody's sitting in front of their laptops for hours on end right now in this makeshift offices. And looking at the mobility of their spine, looking at how that abdominal wall is affecting what they're doing with their digestive system and moving food along and moving the pelvic floor along, because the diaphragm, the thoracic diaphragm and the pelvic floor muscles kind of work in a synergy on day to day with every breath that we take. So if at any end, these two musculoskeletal, if they're to consider the top and the bottom of the abdominal canister, if one is not working, the other one can be influenced. So looking at the whole person. Looking at, we do a lot of manual therapy techniques for the whole spine and pelvic girdle and the pelvic floor muscles internally. Therapeutic exercises, usually we do anything from down training. If you come get in patients that, like Jen was saying, if they've been going on in a very high tone, guarded, really alert system that cannot let go of their muscles, and that's affecting their ability to defecate or to urinate, or they're having issues like that. We can be down train the muscles to calm down a little bit, versus sometimes we have weaknesses and we want to upgrade it. There are some machines that we do use in the world of pelvic floor physical therapy. One is the surface EMG, and real-time ultrasound is something that I use because it helps people really visualize and see their muscles in action. and giving them a lot of feedback visually, along with tactile and verbal cues, but a lot of visual and audio input in terms of for them to understand how their muscles are working or not working. I'm going to discuss a little bit more about the mechanical assessment of the defecation and how the whole anorectal region is not only partially related to the GI system and things that may not move along physiologically, but if the synergy of the movement has been compromised, then they don't create proper intra-abdominal pressure to be able to defecate, is what causes a lot of mechanical dysfunction. So a lot of people come to see me and I'm like, they say I've been constipated all my life. And when I start asking them questions, they're not constipated. They're having a bowel movement every day. They're like type 3 or 4 on the Bristol scale. Their feces looks proper. They've just lost that mechanical ability to create enough pressure to actually defecate for a variety of reasons. Maybe they did have chronic constipation. Now things have been resolved, but the brain body connection have been lost to create that ability to let go and relax and help them with defecation. And then a lot of behavioral modification, especially around the region that we live in. I feel like there's a lot of really crazy type A personalities that work in different situations that are really toned. And I really think sorry for the bad expression, but I think the expression pain in the butt came from somewhere. I think that's because people are really butt grippers or abdominal grippers. And I'm sure, Jennifer, you see that a lot, that people are, you tell them to let go of their abdominal wall and they're like, what? How? And literally, lo and behold, I tell people to let go of their belly and they start having their pain. 50% of the time goes away because somebody had told them, or that's their guarding mechanism. So looking at those behavioral modifications is just really important. And then lifestyle with food, diet, counseling, and all of it. So what is the biofeedback with surface EMG? Some of us may be familiar with that. It's basically not very specific because it's a surface EMG, so it's giving us global information of the region that we're looking at. Psychiatrists and psychologists have used biofeedback for many, many years to address anxiety, migraine headaches, cervical, any kind of headache with, related to muscle tension. But the idea here is to bring something to the conscious level that is otherwise subconscious. So if you have that person that is high tone, but they've become really unaware of what they're doing to their muscles and their body, you attach these sensors to them either externally or internally, which I have a visual of it, I will share it to you. Basically trying to give them visual, audio, or any kind of tactile information to tell them, this is what you're doing, can you apply that to your life, so they can learn this is how the tone is high. Not related specific to this patient population that we're talking about, but I see a lot of people that have pain with sex, which is part of the comorbidity that goes along with people who have a hard time defecating or urinating, or they have incontinence, because it's all of it is interrelated. And I've had patients that you teach them with surface EMG to down train and relax the muscle in the pelvic area by showing them with the sensor that yes, every time something is trying to insert your body, your muscle tone goes up. They get that visual input from their muscle activity, and then we do the down training and they can apply it for self-regulation and doing it at home with the exercises that we may be giving them. So basically it's a awareness that they become, so in terms of generalization, in terms of being able to discontinue a behavior in response to some kind of stimuli or something that chronically has been going on. So they learn different techniques of managing some of the symptoms. So with the sensors that we use, as you can see, this is, there's a rectal sensor that sometimes I use, and sometimes we use the external sensors depending on the person's tolerance. These are just like an EKG. This is how I explain it to my patients, that just like an EKG, we have these externally placed around your heart. We put these external sensors on the perianal area, with the third one on the glutes usually, and it's picking up muscle activity in terms of, if you have a person who can't relax their external anal sphincter, for example, and you want to teach them down training, then you show them on the computer screen, which is very a similar graph as it is with the EKG reading. And we know what the resting tone should be like. Can we reach that resting tone? Sometimes with some of the patients who have dyssynergy, that they're unable to relax the internal muscles, the puborectalis muscle, and open the anal sphincter at the same time for proper defecation. Sometimes I use both sensors. So the internal sensors, which is the top of the image, will give the person input. They would see two graphs. One graph would show them what is the levator ani or the pelvic floor muscles are doing. Can they reduce the tone on that as they open the external sensor that is being picked up by the external sensors as is at the bottom of the graph? So they learn opening. So think about a person who may have paradoxical contraction of the pelvic floor muscles. That is involuntary muscle contraction of the muscles when things should open up to defecate. Or they may have anismus, which is again involuntary muscle contraction around the upper muscles in the anal area. And so you teach them, can you, and sometimes the internal sensor can be used for the same purpose. Can you keep the anal canal and the anal sphincter open as we create pressure from the top with the abdominal pressure? Can you drop the sensor out even? Using the sensor not only for reading what the muscles are doing, but as a feedback for in terms of being able to drop things and defecate. So that's something that we would use. Sorry, no, that's good. The other thing that sometimes we use with the biofeedback unit or by itself is the balloon biofeedback sensory training, which is something that a lot of colorectal doctors or some of the GI doctors that I know use as well. It's basically, I have an image of it coming up. It's basically to help with hypo or hypersensitivity of the rectal canal. So think about somebody who's had super impactment, a lot of impactment in the rectum, and their sensory input from that region of the rectum has become really hyposensitive, because most of the sensation to get the sense of filling in the rectal area and the sense of urge to go to bathroom, if the tissue has been overstretched, those neurons that are giving us the sense of pressure have been really downgraded, and the overstretching of the tissue down there is going to affect them inability to feel the urge. So that leads to more constipation and inability to recognize it. Or somebody who is like hypersensitive. I have a patient right now that with the slightest bit of sense of anything happening in the rectum, she goes and sits on the toilet, even though we know the volume shouldn't be enough for our brain to perceive it as a sense of urge to have a bowel movement. So this balloon training is basically trying to reduce the sensor of that rectoanal inhibitory reflex, which is what happens between the internal and external sphincter. Without going too much in detail, but as you know that the internal anal sphincter relaxes to do that sampling response to see if the muscle, how much of the, what type of feces it is, do I have time to go to the bathroom, can I hold it back? During the process of anal sphincter, internal anal sphincter opening, the external anal sphincter, which is more at the bottom, just attached to the coccyx, I'm going to show you an image of it in a minute, increases the tone for most of us who are potty trained, increases the tone. So the internal anal sphincter knows to close and not have that food coming down further. Sometimes if that synergy between the internal anal sphincter and external anal sphincter has been compromised, this balloon training teaches the patients to kind of calm things down and re-educate the muscles. So basically we can use it to help them push the balloon out for the certain volume. Can they get it out of them to simulate the defecation? And a lot of people who have everything, they've ruled out all the testing, and it's just their inability to expel the feces, this becomes really helpful. And sometimes, as I said, I have the balloon inside the patient while they're attached to the surface EMG, so we can get more feedback that way. So on the next image is that the balloon that you see, the end of the balloon is what is inserted into the patient's rectum. it goes above the level of the pelvic muscles, the levator ani, puborectalis muscle. Then if, let's say, if I want to help them to reduce their hypersensitivity, the other end of the syringe, we fill it up with a saline or warm water. So the balloon fills up gradually, because the body should be able to take them. I mean, you all have been there, that you really have to go to the bathroom and you're like, no, I'm going to hold it. I can't hold it unless, and that's when you have to be able to accommodate a certain volume. But if with only 30 ml of feces, they are responding like, oh, I got to run to the bathroom, then I can gradually increase the volume in that balloon to simulate the impaction and filling of the rectal area, and then teach patients to downtrain and relax around it as we can try to practice, exposing this balloon out of the area by relaxing the muscles appropriately when it's time to do so. So, and about the anatomy of the area, again, with the anorectal area, we have the levator ani muscle, which comes really into the regimens of that I do. I always assess my patients. Are the muscles symmetrical from left and right? What muscles are involved? You guys are probably all heard by now about the squatty potty and how popping our legs up relaxes the muscles around the rectum, which is that horseshoe muscle, the puborectalis, that creates a little kink in the rectum so we can stay, continent. But sometimes there is too much tone and that muscle doesn't relax enough, so that anorectal angle doesn't change enough for it. So the puborectalis muscle is the muscle that is responsible for that. If it's very tight and the muscle cannot relax when it's time to defecate, it's one of the things that pelvic floor PTs go through the rectum. Sometimes if the patient can't tolerate it, vaginally, if the patient has the vaginal orifice, and then help to relax these muscles and assess to see what they're doing. The pelvic ligaments that are in the back of the pelvic girdle, is the two major ligaments in the back. And the other important thing about them is that they're nerves, the pudendal nerves that come from our sacrum and affect and feed and innervate the pelvic area, kind of zip through these ligaments. So if somebody is like a slouchy sitter all day and their sacrum is kind of tucked under them and these sacral ligaments are tight and short, they not only affect the pelvic floor muscles because there's attachment there, but they can start irritating the nerves and cause more tone in the area. The internal anal sphincter, is involuntary. It gives us the most tone in our rectum. So its job is to stay nice and tight until that sampling reflexive, when a little amount of feces, about 30 ml, comes in. And that's when we are continent and we are mentally and cognitively intact, we can tell a difference. Is this gas? Can I pass it discreetly? Is this liquid? Should I run to the bathroom? Or is it just a normal feces and I can hold back until I finish this meeting? So basically that's what the internal anal sphincter is in charge, versus the external anal sphincter, which is a lot more superficial. It's basically subcutaneous, and it increases by increasing the tone. It keeps us continent again by having good tone around it. But some of the muscles, some of the incidents, think about any kind of tailbone injuries, patients who fall on their rectum, on their bottom, and they kind of tuck the tail under, or pregnancy, the baby's head gets involved into the coccyx and pushes the coccyx. A lot of people can have long term, even after a few years, you see women that have kind of rectal incontinence or pelvic floor pain. It could be related to this because the part, along with other things, the external anal sphincter attaches to that coccyx and the external part of the pelvic floor muscle. So it's really important to see that the connection between the anal sphincter itself to the skeletal system in the back, and if your patient has had injury. So I always ask that question: were you a gymnast or were you a cheerleader? Do you ever remember falling really hard that you couldn't sit for a period of time? Because that's any kind of coccyx injury. And then of course, 4th-degree tears during labors, anything that rips through the external anal sphincter. You may have seen some people that have fecal incontinence or inability to differentiate between fecal matter. So the next slide shows you a presentation of where the muscles are. On the top screen, top image, as you can see, the correlation between the rectum and around the pelvic floor muscles. As you can see, all the muscles that kind of embed the pelvic girdle. And then the bottom picture, as you can see, it has a presentation of the external anal sphincter and the internal anal sphincter. And what I want you to look at is on the left side, on the left side of the bottom image, I'm sorry, you can see the levator ani muscle, and you can appreciate how that muscle, as it comes, the iliococcygeus puborectalis muscle, you can see how it comes in to help us with the closure around the rectum. So that's why it's so important to have good ability, muscle control, ability to contract and relax. And in the picture on top, I just want you to appreciate the proximity between the tailbone and where the anal canal and anal sphincter is. And I don't know if you guys, you probably can't see can you see? You can't see my cursor moving. Oh, thank you, Jen. So you can see how there is a ligamentous attachment from the coccyx into the anal sphincter as it comes around. Oops. In the, no, that was perfect. No, you did what I wanted to say and show the anal canal in that. Thank you so much. And then at the bottom, you see that platform of the perineum of the bottom of the top picture. It's right, go up a tiny bit where it's right, yeah, that's basically the pelvic diaphragm, and it's a fascial connectivity. So it's really, that's where people get really tight too. So having the manual skills to release the fascia as much as the muscle becomes very important. So we can flip to the next one. So what are some of the diagnoses that would be appropriate for pelvic floor PT? Basically, if you think of the pelvic outlet obstruction, it's really important is to understand that, you have two different types of constipation. Usually that's what we see in a general term. And I'm sure this group here, you guys could do this lecture better than I can. But if you have a slow transit functional constipation, it's usually people that you've done your testing, you see the images, and you see that people have a slow transit. Now, from anything from Parkinson's patients, any kind of neurological or just, lifestyles sometimes can lead to that. With the pelvic floor dysfunction, you can have obstructive defecation because something is blocking the way for them. So their GI system is working well, their feces is well formed, but something is decreasing their ability to get the feces out. So these are the people that are really important to understand that question that I have a Bristol scale on my desk. I'm like, okay, what does your poop look like? How often do you have to go? Do you have to strain? Do you have to digitally manipulate the rectum or the vaginal area or the perineal area to be able to get things out? Because it could be very telling to see what is causing their inability to block their way to defecate. So if they have a rectostele, if they have an intrastele, basically if the rectum is falling, if their intestines are falling downward, the word perineostele, I'm going to show you an image, is basically they're creating pressure from the top, but the pelvic floor muscles are too weak to kind of hold the rectum open. So the whole perineum drops down instead of hanging on and giving them support so the rectum can effectively open. You see that a lot with postpartum women. You see that with postmenopausal women that have a lot of thinning of the pelvic floor, and their system has been, they have that pressure system can be compromised when they're trying to defecate. Then you can have, any kind of things that we talked about, obstructive defecation without the anatomical alterations would be the dysenergy. They just don't know how to let go of their pelvic floor muscles when things are coming through, and it should be pretty effortless. Now, nobody should ever strain to defecate. And anismus, like I said earlier, it's that premature contraction of that prevorectalis muscle and the other levator ani muscles when the canal should stay open, and it kind of cuts. These are the patients that may tell you, I have to go back 2 or 3 times to get everything out. They don't have that sense of complete defecation. And this may be a good time to talk about people with Praxalgia of Fugax as well. So everybody always says there's nothing you can do about it, but really teaching patients down training of their pelvic floor muscles, addressing if there is any residual muscle tightness or anything in the pelvic area. I've had patients that have had the Praxalgia of Fugax, and they respond well to physical therapy when you teach them, or at least if it comes on, they can kind of manage some of the symptoms better when they know what's going on with their muscle. Like Jennifer said, education is so important. When you tell people what it is and what it's not, it's a very powerful thing. So thank you, Jen. We can move on to the next one. So this is what the normal anatomy is. Normal. This is really not a normal, and this is really a one-dimensional, but just appreciating where that pelvic floor lives and how it closes around our rectum, around the vaginal canal, if the person has a vagina, and the urethra, and the connection between this hammock that attaches from the pubic bone to the coccyx and supports our organs up is what I wanted you to see, the normal anatomy there. And in terms of pelvic floor PT and how we can help is that basically the biopsychosocial approach, like we talked about, counseling is so important with these people who have had chronic conditions. Just going back into what Jen was saying, in chronic pain patients, these people are basically the same way. People with chronic constipation, and a lot of these issues can cause problems for them. And we know that the psychological comorbidities can be anything from with IBS. I'm sure you guys have seen the research behind it, that almost everybody that I see with IBS is, when I start digging, some kind of trauma brought it on for them. So it's so important to get that counseling and asking the right question. And again, not to put guilt on them, not to do. It's so important to know that there is some, and if you know of anyone that doesn't deal with that, I have some resources for women, for people who work with chronic pain or trauma and all of that. Having a great dietitian is so important, to have that part of the teamwork. And then meditation, just like Jennifer was saying, in terms of walking, getting them move, very important. And then fecal incontinence and smearing, what we do usually for it is just, if it's a truly weakness of the muscles, overstretch, long labor, yes, we want to strengthen. But one thing that most people don't know is that a lot of incontinence for urinary and bowel is actually for muscle tone that is too high. A tight, short muscle cannot function. So if they're staying really tight and restricted, when it comes to the ability to close these sphincteric muscles, they just don't have it in them. So sometimes relaxing the pelvic floor and not letting them go crazy with the strengthening is what they really need to improve the fecal incontinence. Fecal smearing can sometimes happen due to the presence of rectocele as well, because you can have some entrapment of the mucosal and discharges that gets stuck in that pocket of the rectocele. I have a picture of it. Next, I will show it to you. And it's really something that they have. They go to the bathroom, they defecate, then they say 2 hours later, I see little smearing or a little residual of the fecal matter in their underwear. And it's so important to ask the right question to see if it's related to a presence of rectocele or not. It's not always a weak pelvic muscle. It may be what gets trapped up there. They get up and walk around, then it comes out. So that's one thing to question as well. So again, in terms of what we can do, if there are, everybody's familiar with the Bristol scale, I'm sure, right, Michelle? In your field, you guys should know what that is. Yeah. So if they have type 1 and type 2, a lot of patient education, getting them to move, getting off some medications if they are causing constipation, diet, water. It blows my mind how many people don't drink water. But Bristol scale type 3 or 4, it would be, so they have the normal bowel movement, normal fecal matter, I should say, but they just don't know how to create proper intra-abdominal pressure, kind of bear down properly. So the pressure from the abdominal wall and the abdominal muscles pushes things through while they keep the pelvic floor muscles relaxing. relax and get things out. If they have any of those prolapsed organs that is causing them to not be able to push things through because they have a rectocele or their perineum is up, you may have heard patients tell you that they use their finger, they do splinting or digitation to push up on the perineum, or they go through the vaginal canal to push back to kind of block it so things can come through. And then, as I mentioned earlier, if there is a dyssynergy, meaning that when it's time to accommodate the pressure from the above, the pelvic muscles should relax. So many times I tell them to open and bear down, and they contract the pelvic floor muscle. So by teaching the synergical movement pattern in the abdominal cavity and into response to the pressure and opening is what we can do a lot of training using the biofeedback and the ultrasound machine. So this is a sample of what the rectocele usually looks like. The pelvic floor physical therapist should be trained to assess for this, to see if they have a posterior wall versus anterior wall pelvic organ prolapse. So usually anterior wall would be more of the bladder, of the urethra falling and blocking. But a lot of people who have a trouble with the obstruction is that because instead of the rectum being nice and tight and supported up there, some kind of fascial damage, some kind of support damage to the rectal itself is causing this drooping of it into the vaginal canal. So this is a device that actually I help to, I'm promoting my device here, but it's basically a lot of women say they put their thumb through the vaginal canal and they push back so they can create a good wall for things to slide in, or they can use a device that helps them so they don't get their hand yucky, but so they can do it this way to get things out better. Or if we go to the next slide, oh, I don't have that, sorry. If they have too much of a dropping of the pelvic floor muscles, they can use their finger to push on the pelvic floor upward so the rectum can open more effectively. Sorry, Jen. So again, these are somewhat more diagnoses. We definitely work with pelvic pain. If we can ask the right questions, you would see that, you know, there is a comorbidities. So if you have a person with GI issues, it's so important to ask, are they having pain with sex? Do they have continence? Are they having even, you know, defecation can be painful. So asking the right questions, you see that it's a broader issues related to these people. And there's definitely a correlation between GI issues from IBS, from, you know, Crohn's disease. These patients end up with some kind of inflammatory response to the what's going on into the guts with the pelvic floor muscles, and they can create pelvic floor help. So we do a lot of manual therapy internally and externally to the whole structure of the musculoskeletal, again using different machines. The home program, it's so important to include mindfulness, meditation, relaxation, taking 10 minutes walk. It's unbelievable what it can do for people, because again, it falls under the category of pelvic pain or chronic conditions. Just like pain can mess with your brain, any kind of chronic condition, if it's like GI issues, can start really messing. So if you can get the same approach that Jennifer was talking about and applying it to your GI patients, it really would be wonderful. But I think we can move on, because that was, so I provided my email address if anybody has any questions. And sorry, I just noticed the time, so I kind of rushed through it, but I hope, can I answer any questions? I hope this was helpful. No questions?
Mm-hmm. That was great, Pani. I just wanted to say too that one of the things that Body Dynamics does so well is combine counseling and nutrition, nutritional therapy. So it's we sort of have between the two of us, we have incredible resources available for patients as you need them.
Yes, definitely.
So wonderful.
Oh,
All
thank
right.
you.
Well, thank you all so much. I really appreciate you taking the time this evening, and we will send a recording and also send the slide decks.
Thank you very much.
Thank you very much.
Very informative.
Oh, you're welcome.
Thank you. Please
Appreciate
reach
it.
out if you have any questions.
All right. Take care.
Bye-bye.
Thank
Take
you
care.
so much.